Welcome back to Premom Health India. Today we are uncovering what might be the single most overlooked hurdle to getting pregnant in India. That is thyroid. Statistics show that thyroid disorders, particularly hypothyroidism, are rampant among Indian women. To help us break down this hidden link, we are thrilled to welcome back one of India's leading fertility experts, OB-GYN and consultant IVF specialist, Dr. Laxmi Sangolli. Dr. Laxmi, welcome back to the show.
Thank you, Judith. It's my pleasure to be back with Premom because it enlightens the woman about their own health and especially the women seeking fertility who are not aware of small blood tests which can help them conceive spontaneously. So I'm very glad this work is done by this very good initiative by Premom, and I'm glad to be here on this Premom platform.
Thank you so much for joining us back, Doctor.
As you said, the thyroid is rampant in India. Statistics say 28% of women in reproductive age group are affected with hypothyroidism. And actually, the thyroid, why women don't go for screening is it's because of its silent nature. The silent nature of hypothyroidism, which mimics a simple fatigue, weight gain, depression, menstrual irregularities. So people think that this is just lifestyle issues or stress, and they don't go for evaluation of hypothyroidism. So their limited awareness among the patients make them suffer with infertility for a longer duration of time. So I suggest we should go for a simple blood test of hypothyroidism or of TSH to know our thyroid level and avoid a simple tablet. A simple tablet of levothyroxine will solve majority of their problem. So the prevalence is 28%, which is, and the silent nature of hypothyroidism is affecting a lot of women with reproductive age group and making them suffer with infertility.
It's fascinating how a gland that is present in the neck, that it affects something that is happening in the pelvis. Can you explain the science here? How exactly does the thyroid hijack or suppress a woman's ovulation?
Yeah, thyroid is a gland which is situated in the neck. It's a butterfly-shaped gland situated in the neck. This thyroid releases a hormone called as T3 and T4, which is controlled by, master gland of whole body of all the hormones is pituitary. Earlier it was said pituitary is the master gland, but now we know that hypothalamus is the master gland. So hypothalamus secretes a hormone known as thyroid releasing hormone. This hormone again stimulates pituitary to secrete thyroid stimulating hormone, that is TSH. So hypothalamus secretes thyroid releasing hormone that stimulates pituitary to secrete thyroid stimulating hormone, and this hormone stimulates thyroid gland to produce T3 and T4. So hormone itself by definition is hormones are chemicals. They are produced in one gland and they act in other place through blood. These chemicals, peptides, proteins secreted from thyroid gland act in the reproductive organs situated in ovaries as well as uterus. So this is how the science. Hormone itself definition, it is a chemicals, proteins which are secreted in one place and act in other place. So the butterfly gland situated in the neck acts in uterus and our ovaries. So what happens is this the pituitary, I said, it releases thyroid releasing hormone. It stimulates pituitary gland to secrete thyroid stimulating hormone. When this thyroid TSH is high. When is the TSH high? In cases of hypothyroidism. So when TSH is high, it makes the brain think that it has to secrete more and more TRH. So thyroid releasing hormone, more and more thyroid releasing hormone is secreted. When more and more thyroid releasing hormone is secreted, along with TSH, prolactin is secreted. So when prolactin is secreted, what happens? This prolactin inhibits LH surge. In my last talk, I told FSH is stimulated in first half of cycle. Then there is LH surge to cause ovulation, and then progesterone in second half of cycle. This prolactin inhibits LH surge and causes anovulation. So that is the reason the people with hypothyroidism also have prolactin levels, and hypothyroidism and hyperprolactinemia coexist, and they cause anovulation, menstrual irregularities, and infertility. So this is the science behind this hormone. This prolactin acts as a contraception, natural contraception. So there should not be hyperprolactinemia or hypothyroidism in patients who want to conceive. So that is the basic hormones which we infertility specialists evaluate. We evaluate for hypothyroidism and hyperprolactinemia.
So, with thyroid, the prolactin also increases, and prolactin acts as a contraceptive, which acts as a blockage in getting pregnant.
It acts as a this normal menstrual cycle. What hormones should be high in first half of the cycle? What surge should be there? What should be there in second hormones? No, those all the hormones are suppressed. This hyperprolactinemia, it affects the GnRH pulses itself. So the FSH is reduced, the LH surge doesn't happen, so there is no ovulation, so there is cycle irregularities, anovulation, oligomenorrhea. This cycle irregularities begin coexist with hypothyroidism and hyperprolactinemia. It is a major cause of infertility in majority of women. So these simple tests of hypothyroidism can solve the problem of infertility in majority of women, 28% of women.
Okay. So, talking about testing, a lot of women get a lab report with a TSH of level between 4 to 4.5. And their general physicians say, okay, that's a normal level. But is the normal range same as that an optimal range for fertility?
So this normal TSH level, what they say for general physician, matlab every men and women, they consider 4 to 4.5 milli international units per liter as a normal TSH level. But for the woman seeking fertility, we told no, there is very high demand of thyroid hormone in this ovaries and uterus. There is endometrial lining in the endometrial lining which also has thyroid receptors, and this FSH and LH, they all require thyroid hormone. So the level cutoff for TSH in women seeking fertility is 2.5. The American Thyroid Association and ACOG, American Conference of Obstetrics and Gynecology, they all suggest that TSH should be of less than 2.5 milli international units per ml for women seeking fertility. So the level of 4 to 4.5, which is considered normal for all the male and females, is not optimum for women seeking fertility. Because when there is hypothyroidism, that is high TSH level, this can be called as subclinical hypothyroidism. We consider this level of 4 to 4.5 in women seeking fertility, we consider this as subclinical hypothyroidism. They do not have symptoms. They may not have anovulation. Their cycles may be regular. They may be thin, but they have recurrent pregnancy loss. They have infertility. So this is called as subclinical hypothyroidism. Though their T3 and T4 is normal, and though their TSH is 4 to 4.5, which is considered normal for other women, it is suboptimum for women seeking fertility, because this is the one which hinders their fertility, which will hinder their implantation, which will hinder their ovulation. So American Thyroid Association suggests that our cutoff for women seeking fertility should be less than 2.5 and not 4 to 4.5. So our target for preconception TSH is less than 2.5. And we should be aware that there is something called subclinical hypothyroidism, where even the range of 4 to 4.5 is going to affect your fertility and is going to cause recurrent pregnancy loss, implantation failure. See, this hyperprolactinemia and hypothyroidism will cause luteal phase defect. Luteal phase defect is something like the second half of the cycle, there is decreased progesterone. So it affects the implantation. So I was telling it affects the ovulation, it affects the implantation, it causes recurrent pregnancy loss. So women who are trying to conceive for years together, again have failure to implant and have recurrent pregnancy loss, is more trauma on the already suffering ladies. So only simple test of TSH, thyroid stimulating hormone levels, will help them to conceive, and the optimum level is very important. This 4 to 4.5 is not optimum for the woman seeking fertility.
Okay, so for normal people, the range is 4.4 to 4.5, but people who are trying to get pregnant, their level should be below 2.5, according to the international standards, right? Okay. So, doctor, what are the symptoms we can see if someone is having thyroid? Is there any symptoms or anything?
See, the symptoms of hypothyroidism mimic a simple fatigue, weight gain. The patients tell that they always feel tired. And then they have weight gain even in spite of eating less, in spite of eating balanced diet. They feel they're having weight gain over a period of 3 to 4 months. Then cycle irregularities like oligomenorrhea, hypomenorrhea, anovulation. So they have this weight gain, they have this subfertility. These are the problems which hypothyroidism presents with. They have cold intolerance. Matlab, a very small little amount of cold, you may not feel it cold, they feel cold. It very mimics very symptoms of PMOS. The PMOS symptoms also have subclinical, they also have weight gain, anovulation, oligomenorrhea, irregular cycles, weight gain. All these cycles are similar to the symptoms of PMOS. But in PMOS, we have other features like hirsutism, acne, insulin resistance causing acanthosis nigricans. This is high. These are the differentiating features between hypothyroidism and PMOS. Otherwise, they look almost similar. So, and actually they coexist. Most of the patients with PMOS also have hypothyroidism. So with the most of the patients with PMOS and subfertility, we routinely check thyroid levels.
Okay, so you're saying that although the symptoms of thyroid and PMOS are similar, it's not necessary that anyone who's having thyroid should have PMOS or vice versa. But mostly people with PMOS have
They
thyroid
coexist.
problems. Yeah, they coexist. Okay, so let's talking so much about all the thyroid and difficulty getting pregnant. Let's leave our listeners with some hope. If a woman is tracking her cycle with Premom app, suppose, they notice irregular cycles, irregular patterns, gets tested and finds a thyroid issue. What does recovery look like? How quickly can correcting those thyroid levels restore her fertility?
Yeah. So this thyroid, when you diagnose hypothyroidism, how do you diagnose hypothyroidism? When we see that TSH is more, it is more than 2.5 in women seeking fertility and more than 4.5 in other women or men. So when the TSH is high, the T3 and T4 will be less. So there is a simple test to diagnose hypothyroidism. That the test is serum thyroid levels. Okay, there is thyroid profile or serum thyroid levels. Serum TSH, only TSH you can do, or thyroid profile, in which there is free T3, T4, and TSH, all the things we diagnose. So thyroid hypothyroidism is diagnosed only by a simple test, by blood test, that is serum TSH, or say a thyroid profile, which is again a blood test, where they do T3, T4, and TSH. So once you diagnose hypothyroidism, it is very simple, very easy to treat. That is, we give simple tablets of levothyroxine. We replace, if there is deficiency of thyroid hormone, give the thyroid hormone. It is available in a small pill, a very small pill. In different doses it is available, from 12.5 to 25, 50, 75, 100 micrograms of levothyroxine is available. And these can be taken as one pill in the morning, empty stomach, and there's nothing should be taken after that for half an hour at least. No tea or nothing. Early morning, as soon as she gets up, she has to take one pill of levothyroxine. The dose is adjusted according to the body weight of the patient. And after taking that tablet, she has to be empty stomach for half an hour. She has to not take anything else for its quick absorption. So this is the treatment. The simple treatment of one tablet of levothyroxine, dose adjusted to the weight of the patient and serum thyroid levels, will regain all her symptoms. She will start weight reduction, her cycles becomes regular. She will have increased chances of spontaneous conception. So as you said, in the patient with who is tracking her ovulation through Premom app, what they can do is they can even visually see their cycles getting regularized in 4 to 6 weeks. In 6 weeks of time, their cycles will become regular. There's LH surge. I was telling the LH surge is not happening because of serum prolactin levels. So you can see visible LH surge. They can see that visible LH surge becomes visible. They can see their cycles become regular in 6 to 8 weeks. So this is a good hope. And once the ovulation is resumed, once the cycles become regular, there is very high chance of spontaneous conception. So this is how I can tell the patients that simple thyroid hormone testing and treatment of this will improve their chance of fertility by 28 to 30%. So I think it's a very positive hope. And their cycles become regular in 6 to 8 weeks.
Okay, so giving the right diagnosis of what their problem is and taking the right treatment, their thyroid can go down. And when they're using the ovulation test and using tracking their cycles on Premom app, they can see visible difference in their cycle patterns, right?
They can see visible difference in their cycle pattern. They can see ovulation happening. The LH surge is, you can see the visibly that LH surge is happening, which was not happening earlier. Earlier, there were no two lines. The LH surge was not at all happening. So now they can visibly see LH surge happening. They can see visibly see ovulation happening. Then with this, all these things, their spontaneous conception chances also increase. So their fertility increases. There will be less chances of recurrent pregnancy loss, early pregnancy loss, because your implantation improves. And you know, one more thing, what the patients assume is they themselves think, I had done TSH level 3 months ago and it was normal. They come after 6 months to you and tell, I have done it 6 months ago and it was normal. They assume it to be normal even after 6 months, 12 months. So it is not the status. The thyroid demand increases in patients who have attained menarche, who are taking treatment for infertility, who are pregnant also. So the demand for thyroid increases in females when they attain their menarche, when they attain their puberty, when they attain their pregnancy, when they want to seek fertility, when they have physiological changes in lactation, the thyroid demand increases. So they think, it was normal 6 months ago, why should I repeat it again? So it has to be repeated. Actually, we have to keep it every 3 months. We have to check our thyroid levels, serum TSH levels, or at least when you feel the symptoms, or at least when you are seeking for fertility. So simple serum TSH levels should be checked like sugar levels. Every 3 to 6 months, you have to keep checking it to avoid weight gain, to avoid anovulation, to avoid fatigue, so to avoid so many complications of thyroid levels. In pregnancy, if there is hypothyroidism, the baby's IQ level will be less. There will be chances of preterm labor. There will be chances of early delivery. Abruption is high in patients with hypothyroidism. So simple thyroid will give a solution for many problems which you don't even know. There is preterm labor, there is abruption, and there is increased risk of high blood pressure in pregnancy. So all these symptoms occur because of hypothyroidism. As I was telling you, early pregnancy loss, they will not even know that they are pregnant, or as soon as they are 5 weeks, 6 weeks, serum beta hcg will be high. That is, she shows pregnancy, but then again she has bleeding. That is all could be because of hypothyroidism. So I suggest not to neglect hypothyroidism and not to overlook it, overlook the disease.
Okay, so doctor, you're saying that, I mean, once we have done, we have a result of our TSH, doesn't mean that that will remain constant. It can fluctuate anytime according to our lifestyle. So it's good to have our thyroid tested within the 3 months of
Please,
3 months period. Yeah. Okay. So, Dr. Lakshmi, thank you so much for shining a light on this silent barrier. It is incredibly empowering to know that something so impactful can be identified with a simple test and corrected so effectively with a simple medicine. At Premom, our mission is to ensure no woman's fertility journey is left to guesswork. By combining easy at home cycle tracking tools with raw data and right medical insights, we want to help you spot these hidden patterns early. If your tracking charts show highly irregular cycles, take that data to your healthcare provider and ask for a comprehensive baseline screening, including your thyroid. If this episode gave you clarity, please subscribe to our channel. Drop your questions for Dr. Lakshmi in the comments below and share this with someone who needs to hear this. Until next time, stay informed, track smart, and take control of your health. Thank you so much for listening to Premom Health India.